Hello and welcome to my channel for audio medical basics to listen to when you don't have the free time or free hands to hold a book. If you like, please don't forget to like, share and subscribe. Today I will be reading another case from my case files book collection, from the case files about the internal medicine. The case today, like the previous ones, most probably inshallah will be divided into two parts because they are long cases, but brief. Nevertheless, today we'll have a hypertension case listed as an outpatient case. So, a 56 years old hypertensive man is being evaluated as a new patient. His blood pressure are in the range of 170/95 millimeters mercury. Fundoscopic examination reveals hypertensive retinopathy. His point of maximal impulse is placed laterally, suggesting cardiomegaly, and a fourth heart sound is consistent with a thickened, non-compliant ventricle. In addition, he has multiple cardiovascular risk factors, including his age, obesity, and smoking. Of course, in the long case, it was mentioned that he was seen elsewhere and diagnosed as a hypertension patient long time ago, but he did not follow up, I suppose. So, the question was, what is the next step in this patient? In such case, first, laboratory evaluation. Second, to start the patient on antihypertensive regimen. And thirdly, to recommend lifestyle changes. This is in brief the answer for the question. So, what is the next step? Laboratory evaluation to evaluate renal function such as electrolytes, creatinine, and urine analysis. Evaluation of other cardiovascular risk factors such as serum glucose, lipid profile, and the baseline ECG to assess for target organ damage. Secondly, to start the patient on a 2-drug antihypertensive regimen that includes a thiazide diuretic. Thirdly, recommend lifestyle changes, most importantly, tobacco cessation. So, the objectives of this case: to understand the initial evaluation of a patient with hypertension, to be familiar with the most common antihypertensive medications and indications and cautions regarding their usage, and thirdly, to be familiar with the various causes of secondary hypertension and when to pursue these diagnoses. So, considerations in this case. This is a 56 years old man with severe hypertension who has evidence on physical examination of hypertensive end organ damage, that is hypertensive retinopathy and left ventricular hypertrophy, as well as multiple risk factors for atherosclerotic disease. The most likely diagnosis is essential hypertension, but secondary causes still must be considered. His blood pressure in the case was above 160/100 millimeter mercury, which places him in stage 2 hypertension, which warrants starting him on 2-drug therapy without further delay. One of the drugs should be a thiazide diuretic. So let's take some definitions here in hypertension. Essential hypertension, also known as idiopathic or primary hypertension, it has no known cause, yet it comprises approximately 95% of all cases of hypertension. Pre-hypertension, when blood pressure 100 to 139/80 to 89 millimeter mercury. Stage 1 hypertension, blood pressure 140 to 159/90 to 99 millimeter mercury. Stage 3 hypertension, blood pressure more than 160/100 millimeter mercury. Secondary hypertension, elevated arterial blood pressure with a known underlying cause such as renal artery stenosis or primary aldosteronism, and prevalence is approximately 5% to 10% of all cases of hypertension. So essential hypertension with no known cause, also known as diabetic hypertension, it is 95% of all cases. Secondary hypertension is 5 to 10%. So clinical approach, initial evaluation and management. Hypertension can first be staged to guide the intensity of medical intervention by measuring blood pressures on 2 or more occasions. Essential or idiopathic hypertension is the most common form of hypertension. As you mentioned, 90 to 95% of cases, and 5 to 10% of cases are secondary. So a secondary cause of hypertension is indicated when a patient have any of the following clinical features: age of onset before 25 years or after 55 years, presenting with malignant hypertension, requiring 3 or more antihypertensive medications, and hypertension that has suddenly become uncontrolled, a rising creatinine level with the use of angiotensin converting enzyme ACE inhibitors, or overt clinical signs of a secondary cause. So, a secondary cause of hypertension, which needs more extensive testing, is indicated when patients have either age of onset before 25 or after 55 years, presenting with malignant hypertension, requiring 3 or more antihypertensive medications, hypertension that has suddenly become uncontrolled, a rising creatinine level with the use of ACE inhibitors, or overt clinical signs of a secondary cause. Okay, so we have a table here about the secondary causes of hypertension, so it's very brief. We have renal disease, endocrine, musculinous. Renal diseases are parenchymal, like glomerulonephritis, polycystic renal disease, diabetic nephropathy, and renovascular. These are the renal diseases that cause secondary causes of hypertension. Endocrine secondary causes: primary aldosteronism, Cushing syndrome, pheochromocytoma, hyperthyroidism, growth hormone excess, acromegaly, oral contraceptives. Other causes are coarctation of the aorta, increased intravascular volume, which is post-transfusion, hypercalcemia, medications like sympathomimetics and glucocorticoids. So this is a quick table of the secondary causes of hypertensionity. Okay, now we go for other cardiac risk factors and evaluation for target organ damage. Cardiovascular risk factors and hypertensive target organ damage should be identified. The major risk factors of cardiovascular disease are age, cigarette smoking, dyslipidemia, diabetes mellitus, obesity, kidney disease, and a family history of premature cardiovascular disease. Target organ damage of hypertension includes cardiomyopathy, nephropathy, and retinopathy. Target organ damage. A complete history and physical examination, including fundoscopic examination, auscultation of the major arteries for Broots, palpation of the abdomen for enlarged kidneys, masses, or an enlarged abdominal aorta, evaluation of the lower extremities for edema and perfusion, and a neurological examination should be a standard. Okay. We have here other table for the basic tests for initial evaluation of hypertension. These tests are urinalysis for protein, blood glucose, and microscopic examination, hemoglobin or hematocrit leukocyte count, serum potassium, serum calcium and phosphate, serum creatinine or blood urea nitrogen, fasting glucose, total HDL and LDL, cholesterol and triglycerides, electrocardiogram, and consider thyroid stimulating hormone. And so that is all for part 1 for this case about hypertension. We'll see you in part 2, inshallah. Thank you for watching. Please, if you like, subscribe and share.